I think my brief tonight is talk about PCR diagnostics for COVID-19. And I'm not sure whether there was a question mark or not, but I've added that in. So I just thought I would start with, this is a simple little slide that I've drawn, so it's not particularly beautiful, but it shows what we're trying to achieve with PCR. So most patients on average have an incubation period of around about 5 days. And then you start to, in the respiratory tract, be able to detect the virus. And that's where they present with fever and cough. And so this is the time point where we can do PCR. And then over time, they will start developing IgM and IgG. And actually, I think the IgM and the IgG pretty much come up at the same time, but this is 14 plus days. And so the thing we're trying to diagnose with PCR is the infection in the first sort of 7 days of illness presentation. So anything with diagnosis is about going from the patient and getting the sample, and admittedly you wouldn't in ITU have to get into a car to get your sample, but you know, it was just a picture that I had. And then you have to get that sample to the right place, and then it has to come to the lab, and then very importantly it has to go back to the patient. And put another way, it's thinking about the right time to sample the patient, the right sample, the right transport, the right test, and then the right action on that report. And all of those parts of the process need to be in place to get a good diagnostic result. So when it comes to looking at the right time, I've done a bit of analysis of some of the data, and I thank some of the registrars who've done the analysis on this as well. And asymptomatic is a little bit of, we don't encourage this, but we have got it does happen sometimes. And we've tested a few of these, and then positives there. And I know in the literature there are positives in the asymptomatic phase, but we haven't encouraged that. And the vast majority of our positives are in when people are symptomatic with fever and cough. And then we have those with atypical symptoms, and that's been a thing that's been emerging in the last sort of month or so, as we're starting to see more elderly patients presenting with COVID-19. They're not necessarily presenting with fever and cough, presenting with confusion, diarrhea, and sort of loss of ability to walk, so losing their gait. And again, we've seen sort of relaxing of the criteria, and that being included in patients that we're testing, and we've had a lot of positives in that area as well. So when it comes to the right time, PCR is best performed in the first 1 to 7 days, and testing out with that time, with the date of onset is many days before that. You're really trying to sort of push PCR to its complete limits of performance. Elderly patients may present atypically, and then usually if you start trying to test more than 10 days after date of onset, it's more difficult to get a positive result. And so this is what we have, as we always say, as they're coming into hospital, take the sample there and then, because that's going to get your fastest diagnosis and your infection control measures. In the community and the key workers that we've been testing, we tend to say test at 24 hours up to 4 or 5 days, because it allows a day for the administration to work, and so then people aren't wanting getting het up about not getting swabbed on the first day. So this was when we, early on, so when we come on to what's the right sample, early on we were able to follow patients, the mild patients, and we took very avidly nose, throat, urine, stool and EDTA blood in all the mild cases that occurred first on. And what you can see is that essentially nose was the one that gave us the biggest yield and positive results, and was positive. This is sort of an average of all CT loads put into a sort of visual format, and so the nose sample was the best, and then followed by the throat. Urine was always negative, stool was once or twice positive, and EDTA blood was always negative in these mild cases. So really the best sample in the mild cases is a nose swab, but we still do a combined nose-throat swab as the best sample, and really all the other samples for the acute phase in these mild cases don't add anything. But then when you come on to all the cases that we're seeing in hospital, and this is a chest x-ray taken from a patient, and you can see the devastating impact of this disease in that chest x-ray. So in ITU, we've done an audit, and we can see that 65% of our cases are positive with a nose-throat swab on admission, whereas 100% of our cases are positive in the tracheal secretions. And if you take the two together, we get 98% diagnosis in ITU of clinical COVID cases. So the clinical criteria being on the top line, which is very good, but it shows you that the problem is that we can't often sample the lower respiratory tract because we can't do induced sputums, and it's only really ITU where you can get your enterotracheal secretions and or a bowel sample. So just to summarize on what's the best sample, so a nose swab when the mild, nose throat swab in a mild presentation, and if you can get a lower respiratory tract sample for the for those with the lower respiratory tract, which are most of the people in hospital. So the next thing is the right transport. So this is Edinburgh with the First Force, and these are various hospitals that send us samples. And what I just point out here is that blue is 1 day and orange is 2 days. So we're doing a test that takes 4 to 6 hours. You can see how many of these places across Edinburgh are taking more than 2 days to get their samples to us. And obviously some of them are taking 2 days, but even 3 days to get their samples. But actually what's been great about COVID is you can suddenly, you know, change the landscape of this. And obviously the army is very good and they get all their samples on the same day. But now we've been able to have more and more vans running around the city. So we've now actually got all our samples, virtually all our samples arriving on the same day or taking 1 day. So that's been a big change and makes a huge difference to the turnaround of things. The army still gets a gold star. And then we come on to the PCR test. Which, so when this was published very rapidly in January, 22nd of January, so it was a collaboration with European groups, and they looked at various gene targets and came up with a PCR. And so we were part of Edinburgh, part of the rollout in the UK, and controls were sent to 12 labs, and we all used an in-house assay based on this polymerase gene, which is relatively conserved. And the controls were dispatched 5th of February, and we went live in Edinburgh along with Glasgow on the 10th of February. There were definitely challenges with all of this because there was a lack of positive control at this stage, and there was also a lot of contamination of primers, which hampered the contamination of the primers from the companies at this stage. But since then, we've got quite a lot of machines in our lab, and we've pretty much put this PCR on every single one of them. And I'll just sort of summarize. So we've got 2 in-house PCRs based on the E-gene and the RDRP, but we have validated the Altona assay, and as you can see, there's a whole range of gene targets, which over time, there's N and there's S, and I don't think there's a consensus on where the best gene target is. Some can say that N, so the nuclear protein might be more sensitive because the way the virus replicates, that gives you a site multi-copy approach, and so that might give you more positives. But then there is the potential that that might give you some false positives. So a lot of the assays that just have the N on their own call them an inconclusive result and might need secondary work. So certainly Caffeine has that, and Roche has that as well. And we've done a whole range of positives, and we've done specificity on each of them. And really, for the vast majority, they all have a lot of agreement, and they're all a lot of really good assays. We haven't done too much with the QIAstat as yet. And the BDMAX kits haven't arrived yet, so we haven't done too much on that as well. It's enabled us to have a lot of different options when we're doing our testing. So this is what's happened in Edinburgh. So we went live in Edinburgh in early February, and then we started testing, and then there's various different implementation points that came along. So first of all, we had to test all ICU, regardless of whether they'd been traveling anywhere. And then our cases picked up, went above 1,000 in a week, and then the call came to test all hospitalised admissions, but to stop community testing. So that made things drop down a bit. And then we brought in testing all key workers, and that's basically put our numbers up a lot. But then as sort of lockdown has come into play, our numbers have come down, and you can see the sort of positive rate is sat around the sort of 20% level. And so these have been some of the issues around the pathways that we've had lots, and all the labs have struggled with this. So swabs have been massive problems with getting swabs and supply issues, and there have been massive problems with getting particularly extraction. And we've been very lucky in Scotland to have our national services and one sort of hub for procurement. So this has all been dealt with centrally, which has put us in a sort of a place where somebody not having to go around lots of different health boards. So this is what we've managed to set up in Scotland. So from some of our validations, so the Altona assay, the C-gene assay, and really every single health board has got options. In Edinburgh, we've got several different assays live, but including all the islands, have now got CEFID. So it's been a huge work by a lot of people to achieve that for the whole of Scotland. And currently we have a capacity around about 3,000 a day, but we're testing way below our capacity a day. And that's been the case for really pretty much the last month or so. So when it comes on to looking at PCR performance for clinical COVID diagnosis, so again, we've looked at the whole cohort. We did this a week ago, and so we have a certain number of cases. So this is looking at cases that were all negatives, that's 79%, and then we've got those that were positive at diagnosis, that's 18%, and then we've got those that were negative, and then they were followed up with a positive case, and that's 1.5%, and then we've got those that are negative and we've never got positive by our PCR, and they're sort of called presumed COVIDs, and that's 133 cases, which actually ends up with the PCR being having a sensitivity for clinical COVID of 91%, which is pretty much in line with what others have described, but maybe higher than I was expecting. And the specificity and positive predictive value is 100%. So the other really important thing is PCR only works if it's all set around clinical algorithms, and we've had some very enthusiastic people who've said no one can read documents of words and words and words, and have put everything into flowcharts. And this is just one saying, right, you're trying to discharge somebody and what you have to do, and you flow through that. And then one of the other flowcharts we've done is what is the value of repeating negatives. And so here I'm just showing you, if you're negative on, do the second test and it's positive. So we've had 99 in that group. That's 82% of the ones that have been repeated. And really, you very quickly get very low diminishing returns. So we've had somebody who's had 3 negatives and then they test positive, and we've had 6 who've had 4 negatives and then they test positive. We've had one person who's been tested 5 times and negative and then they go positive, which does make you wonder whether it really was there in the first place or it's been acquired in the hospital. So what we've been able to do is come up with an algorithm called, I think my patient has COVID, but the virology swab is negative. And this is to say you only get one second choice. You can be negative and then you get one more, and then you have to look for other pathogens, because a lot of the time all the other respiratory pathogens are being forgotten, and there are still other respiratory pathogens around. So that's and they shouldn't test the 3rd and the 4th and the 5th and the 6th. time. So looking, this is our turnaround time, looking on average is 12 hours. And this is the whole system, so patient back to patient. We obviously have a few that don't quite have, for various reasons, take a bit longer. And the final thing to make a result work really, really well is to get the right results back to the patient. So all our results go automatically. We don't, initially we were doing a bit of sort of interfering with the, well, not interfering, but just for us pressing the computer. But now we let all these results go automatically, and they go into the patient notes, and we enter results and comments from infection control purposes into the patient notes. The GP links go into Sky Store, and they get a prompt to say that there's a result to look for. There's Health Protection have a shared data sheet, so they don't call us, hope that they can share this data sheet. And HPS have a data feed called ECOS. And our infection control have something called ICNet. So again, they get an automatic download. And then we have a team called the Data Analytics who do amazing work, and they can tell you at any time point how many people in the hospital and in which ward and all sorts of things around who's got COVID. And then I'll just finally summarize with just a bit of Will's here, and he loves rugby, although maybe not quite like this. But this is my daughter playing rugby, and I think this just is, we're in a really tough match. It's been really tough getting all this PCR going, and we've been on the front line, which is not usual for us in diagnostics. But we've had a referee, which sometimes might feel like the government, but sometimes might be even more divine than that, and sort of, and we've had to get this ball down to the end of the line. But we've absolutely had to have a team around you, and this is, nothing's been stronger than having the team around that's been working on this. And there's also been people watching from the sidelines. Not all of them have been helpful because they're on the opposing side, but some of them are cheering us on a lot of the time. But some of the time it gets a bit rough, and it gets a bit illegal, and it gets a bit tough, but you have to keep on pushing through, and then you get to the line. And but then we're in a tough match, so there'll probably be another 3 tries against us, but we can come over that. So I'll just summarize there, and I hope I haven't overgone too far. But so a sample for PCR diagnosis between 1 to 7 days. It's absolutely best when they're symptomatic. The nose is better than the throat. Lower respiratory tract sample, you need your lower respiratory tract sample ideally, but I know that's difficult. And PCR, you have to keep monitoring the performance, and there are lots of different options out there, and it's a challenge keeping up with all the different connotations of PCR. And then you want to make sure your PCR links to clinical guidelines, and it isn't just a test on its own. And finally, it's a big team, and there's lots of collaborations, and it doesn't work unless it's all part of a team effort. And I just listed a few of them, and I hope I've got lots of them at the end. Thank you.
Thanks, Kate. Thanks very much indeed. There are a whole range of issues that you've covered there. I have a number of questions that have been sent through, but I'd encourage everyone who's listening to type in your questions now. So first thing, nose swab is better than throat swab. I haven't appreciated that. Why do you think that is?
It is different too, because for flu and things like that, the throat swab seems to work really well. I imagine it must be something to do with where the virus is replicating in the body. I mean, we have all these reports from the Zoe app that people lose their sense of smell and their sense of taste. So it must be something to do with that, but I don't know. Maybe there's others out there that know the reason why.
Okay. I just wondered if it was just easier to take a nose swab than it is to take a good throat swab.
Well, there could be that too, but when we have, very, so they make sure that the throat swab, there's sort of a video that's been produced, and the voiceover says, make sure they gag for the throat swab and make sure their eyes water for the nose swab. So there's definitely a lot of wanting to have pain to make sure we get the right sample. But it's very frustrating, because what is different about this virus is everybody really, really wants to get the diagnosis and they can see the clinical picture, but we're not actually getting, you know, with the other viruses, we tend to get the diagnosis right at the start, and they have this sort of progressive disease, and we're not necessarily always getting it first time, which is very frustrating.
Okay. On one of your slides, you indicated that you've got access to CEFID tests.
Yes.
Is that widespread? We don't have that here. I don't know if other labs in England have access to CEFID. If you do, send a note. But we don't in Nottingham.
Well, we have it in a few health boards in Scotland. So particularly the Islands, Shetland, the Western Isles, Orkney, because it seemed like the best option for them. And I think this is where, working together as a big unit as Scotland, we've benefited from that. So we've been able to say this is how many we want, and this is for the whole of Scotland. We've done the validation in Edinburgh, and then we haven't actually got it. We would love to have it for Edinburgh as well, and we hope to have it, but yeah, the kits, I think they're manufacturing the kits in Sweden, and so I think they will all arrive, but okay. They are a bit thin on the ground as yet.
I've had two messages. One is that Hull have CEFID, and the second is that Nottingham do have CEFID as from yesterday. So let's move on swiftly to false negatives. So you would accept a second sample if the first one is negative. When we did our local audit a while back, the yield from second samples was in low single figures.
Yeah, I mean, it's not great from our audit either, but I think we probably didn't jump on it as quickly as you did. And so we've slightly got to the, and we have had, well, we've had, what's that, 8% has been positive on the second sample. So it's not as big as the first sample, but it's not insignificant. So.
Okay. So to move to some of the questions from the floor, a couple of people have asked about post-mortem testing.
Yeah.
Have you been asked to do any? And if so,
yes.
What sample and what's the yield?
So we started on Monday, so it's not exactly been going for terribly long, but we certainly had positives, but I haven't looked at the data to say how many of total we've had and how many positive we've had, but we're testing the lung tissue. Okay.
Urine and stool. We've looked at stool. We do find some positives in stool in patients who are throat swab negative. Are you encouraging that or not?
So I know that there is 15% that are positive in the stool. I think that they tend to be positive in the stool further on in the illness. But we've found that when we looked in ITU, we got very poor yield from testing the stool, and people weren't very consistent at sending it. So if they have diarrhea or something like that and you get the stool, then maybe in these elderly with these atypical presentations, but we really think that there's probably the need for the antibody test at that stage, because you're so far into the illness and the date of onset that would be a better use of diagnostics.
Okay, an infection control question. Have you tried swabbing any surfaces, and can you pick virus up on surfaces using PCR?
You can definitely, because that's been shown. I'm sure we probably should be doing environmental swabbing and doing PCR with the amount we're doing. I have to say, hand on heart, I'm not sure that part of our quality program is quite operational as yet. But yeah, so I think looking at using PCR for environmental monitoring would be, and in ward areas might be interesting.
And a similar sort of infection control question is, what tracing happens when you have a positive? I think I know the answer to that, but what are you doing in Scotland?
What, so from a ward perspective?
or no, just any contact tracing of a positive patient? Is that happening?
I mean, there's very little contact tracing happening right now. I mean, everybody's gearing up to thinking about contact tracing when potentially the lockdown changes. But at the moment, because we're mostly testing in the hospital or in care homes, and generally by the time we're testing in care homes, there's quite a lot of positive cases, that we're not actually doing too much about thinking about where it might have come from, because it's quite a difficult question at that point. But contact tracing I think is something that would be great to do with our key workers. So, you know, you've got lots of healthcare workers and others who are testing positive, and then to do some contact tracing around them and start to sort of build up your repertoire of how to do this in the world where, you know, we've still got PCR capacity before we move to the sort of post-lockdown phase.
Couple of questions about reinfection or second infections. Have you come across it? Do you think it's real?
No, I expect it's just PCR, you know, blipping along, being positive. And because we certainly saw that when we followed up all our ITU patients, that they could go positive and then positive for a while, then they're negative, and then they'd be positive, and then they'd be negative, and they'd be positive. And they were, you know, they weren't reinfections, they were just all the same thing, and the PCR just being at the end point of its sensitivity, and sometimes be positive and sometimes it's negative. But probably there does need to be a definition for that, because it has been reported, and I think we probably need to get some good data around the fact that there probably aren't, you know, whether there are reinfections or not.
Okay. I'm getting a bit of an echo. There's been a couple of questions about antibody testing, and I won't put those to you because the session in 2 weeks' time will be devoted to antibody testing, what it can tell us, can we do it, are the tests any good? So do come back in 2 weeks' time for that one. Can I challenge the logic of your, I was trying to read your algorithm, but you moved it too quickly, on swabbing to allow de-escalation of isolation?
Oh, yes.
If after 7 days, from your own data, the positivity rate in genuine cases goes down considerably, then is there really a logic in testing after 7 days in order to allow you to de-isolate a patient?
No, and that was an old algorithm, and we've changed that. So, there is what we think scientifically, and there is then what we get told to do because that's what we get told to do. And sometimes we can inform that decision making, and sometimes we can't. And so we have been asked to do some discharge screening, even though we don't think there's any value in it, because it's not really informing anything, but it just gets put into the policy.
How do you interpret it if the sample 7 days later is PCR positive? Because it doesn't tell you that it's viable.
No, so but then you have this quandary. So you've got a PCR positive result. So really, if you're trying to get the person discharged or wherever you're trying to do with them, and they're fit to do that, that's the main thing, is they're clinically fit to do that, is you just say they were positive, they're still positive effectively, you need to put them in we have these red and these green zones. So red COVID, green is non-COVID, and so everywhere you de-escalate them to they would go into your red zone of wherever your discharge place is, whether it's a primary care hospital or a nursing home or wherever that is. But it doesn't actually change with the PCR result, but people really fixate on the fact that they want to see a negative because that would just, you know, make them feel happier, but it doesn't make any scientific sense.
No. Okay. Are you doing any full-length sequencing to monitor clusters or transmission networks?
Yes, we're part of the COG UK initiative, and so I think Judy's speaking about that. So we've done some work on that. We're sequencing around about 100 to potentially 200 a week sequences. But we're doing that for, between Glasgow and Edinburgh, we're doing that for all of Scotland.
Okay. The latest question is, have you had any carriers? I guess the issue is, do you think there are some patients who shed virus over long periods of time, so-called super spreaders?
I mean, we've seen people remain positive for 3 weeks, 4 weeks. I think I haven't kept on following up to see if they stayed positive after that. I'm not sure those people are super spreaders. I think super spreaders are maybe more of an event where somebody is very, very viremic, or not viremic, but has a lot of virus in their upper respiratory tract and just is able to infect a lot of people by whatever proximity they are. But we have seen people who do stay persistently positive, but again, it's by PCR, and I'm not really sure what that quite means.
Okay, testing of staff members, what criteria do you use to test? Is it just staff members who are self-isolating who you want to get back to work?
No, it's pretty much anybody. Is, you know, if you're symptomatic and you are on a ward with COVID, you get tested. If you're self-isolating at home because you've got somebody else who's got COVID, you get tested. If you're symptomatic yourself, you can get tested. If you're yeah, that's pretty much it, I think. But the person that's being tested is always the symptomatic one.
So I think we might make this the last 1 or 2 questions. Have you any experience, this is an interesting one, of testing CSF? Oh, you've frozen.
I've asked this question to a few other people, and yeah, you froze too. I've asked this question to a few other people, and my view here is that if you're worried about them from the patient from their sort of CNS perspective, it's probably the inflammatory response to the virus, and you'd be better looking for intrathecal antibody. And we get asked to test CSF in flu, mycoplasma, all sorts of other infections, and we never find it by PCR. And I don't think COVID will be any different. But this is where we have an intrathecal antibody test, because I think that will be the relevant test to do. And I've seen a few cases where people have done CSF PCR and it's negative. But.
Okay, mentioning other viruses, somebody has asked, are there any other viruses that you're picking up in your COVID negative patients? What's circulating at the moment?
So our kiddies still have, you know, full range of, you know, so this is Scotland. We have got a nice sunny day at the weather at the moment, but you know, we've still got RSV, we've still got rhinovirus, a lot of adenovirus, and a lot of mycoplasma pneumoniae, and those are probably the main other things we're picking up by PCR.
Okay, so that's an important message, because we felt there was a lot of focus on COVID, and other diagnoses went out of the window. But
and I think the microbiologists are seeing, you know, patients with strep pneumo, Haemophilus influenza. They're seeing really significant bacterial infections that are just getting overlooked.
Yeah, okay. This is the last one then. The sensitivity data of 90%, that was of patients tested within 7 days of onset of symptoms.
No, it's the total cohort, so a lot of them will be beyond 7 days, because that we couldn't control that.
So I think you're doing well there, because I've seen figures quoted as low as 70% false negative, you know, sensitivity. In other words,
thank you. Thank you.
Must be all out. Okay, that's a good note on which to finish. Thank you everybody for all your questions. There's been a whole stream of them. I hope I've covered most. Thank you very much indeed. I hope you found it informative, and I wish you a very good evening. There's still a little bit of sun outside, so go away and enjoy that. Thank you very much indeed.